Welcome to the silent disco, also known as the GMC, Reforming Medical Education and Training to support an evolving workforce and population. And we're delighted to welcome you to this session today. As you know, things running slightly out of sync because of changes to the programme this morning, but hopefully have the opportunity to still have our good 30 minutes conversation today to really get under the skin of this issue. We know that today's generation of doctors really want to focus on having different types of careers and life choices, but obviously the needs of the patients that they serve is also evolving. So what we're going to do today is talk to two really great speakers who are going to give us the opportunity to understand those changing patterns and preferences of doctors in training and think about how we support the choices that they make. We're going to think particularly in this context about what employers can do, even in the context of really significant service pressures. And then finally, we're going to make sure that we think about the opportunities to evolve traditional training routes so that the profession benefits, but particularly the patients and the public also benefit. So in terms of our panelists today, we have Charlie Massey, who is Chief Executive of the General Medical Council, and then we've got Dr. Nicolette Morgan, who is a consultant orthogeriatrician at University Hospitals Leicestershire, and they're each going to talk for about 5 minutes or so, and then we're going to ask for Q&A from you. So very interactive session. If you want to speak, please do raise your hand and someone will bring a microphone to you, but we hope to keep it as interactive as possible. So start thinking of your questions now, please. But I'm going to hand over to Charlie first.
Thank you very much, Saffron. I always find the silent disco thing a bit disconcerting, but I hope you can hear me well. I can see some reaction, so that suggests you can. So I was going to talk a little bit about some of the data that we published earlier on this week, and really just try to draw out from that some of the implications for the health service and for employers in particular. And I'm also going to look a little bit forward to what the long-term workforce plan says in terms of reforms to medical education and what that means in terms of how we should be preparing ourselves for it. So I'm going to talk a bit about what the data says about postgraduate doctors, a little bit about the growth in SAS and locally employed doctors and what that means, and finish with that kind of longer-term piece. So in relation to postgraduate doctors, there may be a number of doctors in the audience here, but the kind of the needs and desires of postgraduate doctors now, I think, is very different from previous generations of doctors, and different in many ways. They are a group that are much more diverse. They are more overseas educated, more ethnically diverse as well. But they also have different needs. Expectations of working life are very different, and this isn't something that's exclusive to healthcare. It crosses many different sectors. And we see that in our data. So our data show that many more of these doctors want more flexibility, and that itself in different ways. So for example, postgraduate doctors have always taken a break in training, but what we've seen now is that is much more clustered after doctors have completed their 2 years of foundation training. So just about a decade ago, just over a third of doctors would typically take a break after they completed their second foundation year. Our last year's data shows that's over 2/3, so that's kind of more than doubled in just a decade. And quite often the response to that is for people to feel very threatened by these changes in the workforce. And I guess my punchline is that this is something that we need to get better at recognising and embracing. And indeed, we did some research with the University of Nottingham, and that showed that doctors who've taken a break generally feel that they are better able to make decisions about training. They're more confident in their clinical competencies, their wider generic skills as well. So I think we need to recognise that this is a new reality that we need to work with, and we need to reflect on how we can embrace that flexibility. And I guess that brings me to SAS and locally employed doctors. And this is the fastest growing cohort within the medical workforce. I would argue that the medical workforce has transformed beneath our feet. This group has grown by 46% just in the last 5 years. They now outnumber GPs as a group. Of course, I am mistaken to talk about SAS and locally employed doctors as a single group. This is a very heterogeneous group of people, and indeed our latest data disaggregates SAS doctors from locally employed doctors, demonstrating that actually it's locally employed doctors where we've seen the greatest growth, with a doubling of locally employed doctors to over 22,000 on our latest data point. And that's driven to a very significant degree by the growth of overseas trained doctors in our workforce, as well as, of course, there being a number of UK trained doctors stepping out of training by choice, or indeed more doctors stepping into SAS roles by choice. But too often, I would argue, these groups of doctors are not sufficiently valued in the system. They're certainly not represented within the political narrative about consultants and trainees and GPs, and yet they are the fastest growing group of doctors. And I think the punchlines for us all are thinking about how do we capitalise on this group of doctors. They are a talented group of doctors on whom we rely enormously. We need to think about how we deploy these doctors to where there is greatest need. I was a little bit provocative a year ago by saying we need to think about how can we deploy more of these doctors into primary care settings, which I stand by my view on. It's not straightforward as to how we make that happen, and it's not in any way trying to devalue the really important and specialist role that GPs do. But we also need to make sure that we recognise the overseas nature of this part of the workforce. So the questions about induction, training are really important. And there are many places that do this brilliantly well. One of the trusts that Amanda mentioned in her speech, United Lincolnshire, I heard from just last week about the things they've been doing to induct overseas trained doctors, nurses and other healthcare professionals. Finally, I just wanted to mention the long-term workforce plan and what that means. And at the GMC, we very much welcome the plan and the ambition within it, and indeed the funding. The Secretary of State earlier talked about a fully funded workforce plan. There's a lot of funding. It's not fully funded. £2.4 billion, though, is a very healthy and hefty slug of money that we should all welcome. And of course, in the medical side of things, the doubling of medical school places over the next decade is a fantastic commitment. I think I was quoted in the media on Monday about describing it as brilliant. But of course, two things. One is that isn't going to lead to an immediately deployable increase in the medical workforce. So we have to be good at retaining the doctors we've got, and we need to recognise the continuing importance of overseas trained doctors in our health services. And the last thing is around recognising the importance of training. So our data shows that trainers are amongst the more stressed and burnt out groups within the medical workforce. So if you just think about that and then think about the commitments about doubling medical school places and what that means about clinical placement numbers, postgraduate training, we have to be better at protecting and valuing trainers and time for training. And I think that's a real challenge for employers, because when the service pressures aren't going to go away, we've got the workforce we've got. So we need to think about how we can do both at the same time. I know that's not an easy thing to say, but I do think it's absolutely critical to protect the future pipeline of doctors. I'm conscious that I've probably exceeded my 5 minutes, but so I'll stop there. But hopefully that tees up some of the things that Nikki's going to say as well.
Yeah. Okay. So over to you.
Thank you. I'm really pleased to be able to share some of the work we've been doing in Leicester to sort of grow and support our medical workforce. Just a couple of words about Leicester itself. We're the largest city in the East Midlands. Our population's been described as super diverse, and we've been designated the first plural city, so there's no single ethnic majority here. I work in the large acute trust of UHL, and like our population, our workforce is extremely diverse. As Charlie said, one of the groups I'd like to talk about today is our locally employed doctor workforce. We've seen significant rises in the number of young doctors joining us who are predominantly from international medical backgrounds. So we estimate that about 90% of our locally employed doctor workforce are IMGs. We currently have about 1,000 doctors in training, or nearly 500 locally employed doctors and about 110 SAS. And we know that we've been needing to take active steps to both continue to attract these doctors, but also more importantly retain them in UK practice, because there's quite a rate of leaving in the locally employed doctor group. So over the last sort of 6 or 8 years, we've been doing a lot of work listening to and learning from the experience of these doctors. And one of the things we've invested in and taken the decision to form is what we call a clinical fellowship programme. And what we're aiming to do is mirror some of the training and support mechanisms that exist for our established doctors in training for our locally employed doctors. It has required investment and a dedicated team, but given the significant numbers and also the talent and skill that these doctors bring, and also in terms of patient safety, we know that we need to train and teach them well. Through all the work that's been done recently, we know what good looks like. We've got nationally derived induction documentation. We've got the Welcome to the UK GMC workshop, which is very helpful. So we know what helps our new colleagues integrate and navigate a new system smoothly. Some of the key things that we've found are actually having a buddy, having a supernumerary period, and having really robust clinical supervision and feedback are all key elements for this group. We've also got a number of other locally employed doctor roles, and these are the ones that Charlie's mentioned really, that allow people to take that break from clinical training. So we've developed quite a large cohort of what we call clinical teaching fellows, and these allow doctors to take a break from full-time clinical medicine, take a break from the on-call rota. And it's sort of a win-win situation, because they do their own projects, but they also help teach and supervise and educate both the locally employed doctors and also our undergraduate students. These roles have been really popular. We've also invested, we really want to develop the next leaders. We want all our doctors to participate in this. So we've also invested in chief registrar roles within the various departments. And these roles have dedicated leadership and training and management time. About 40% of their working week is that. And in a large organisation like ours, it's really important that we hear from all our doctors about how they're feeling. We know we need to address burnout and morale. So the chief registrar roles have been a really conduit for communicating with the executive team and the medical director team. And one of our chief registrars currently has been really heavily involved in supporting our international medical graduates, and his work really has been integral for the co-design of our fellowship programme. And then lastly, I'd like to touch on the other group that Charlie mentioned, which is our specialty and specialist grade doctors. We had the national contract introduced in 2021, and I think this gave us as an organisation just a chance to really look at this group of really senior doctors who are substantive, who have so much experience in terms of, they're here year after year. They're not rotating around like our junior doctors in training, and they offer all sorts of continuity of care. And what we know is in our population in Leicester, a lot of this group are from black and ethnic minority backgrounds. We know there are well-established problems with differential attainment, problems in career progression, recognition of expertise and support. So what we've done is to work closely with them. We've made some new appointments to the specialist grade, so we found that some of our specialty doctors were working at a specialist level, so we work to recognise that and get them into specialist post. And we've also tried to address the sort of morale aspect by appointing an SAS advocate, which is also a new national role as well, and that's been really positive, and developing a more sort of active forum. So not wanting to overrun my time and being able to take questions, I think in summary, given we're all aware of the unrelenting pressures the whole health service is facing. We know we've got high vacancy rates and rising levels of burnout reported in the report this week. So I think it's really important that we just rapidly provide better support and development for all our doctors, whether in training or in locally employed positions. And also the SAS group, I think, have a lot to offer and can help support training, education and appraisal and leadership development as well. That's all I'd like to say at the moment. Thank you.
Thank you so much, Nikki. That's great. And I'm going to open it up to questions now. If you've got a question for our panellists, then please do let me know. Yep, we've got one from Richard here.
Hi, I'm Richard Scullen. I'm chairman of County Durham and Darlington NHS Foundation Trust. We live in an incredibly poor part of the world with educational attainment at a rock bottom level for children from modest backgrounds. Something I'm particularly interested in is the medical doctor degree apprenticeship, of which nobody's spoken about here. And I was hoping somebody would at least mention, because this has the opportunity for us to go into schools to really push this into people who do not have the advantages of education.
I think that was probably for me. So thank you, Richard. I think it's a great question. So I think the idea of opening up medicine to kids coming from a much wider degree of socioeconomic backgrounds can only be a really good thing. We want doctors to represent the population that they serve, and the honest truth is that isn't where we start, and I think medical degree apprenticeships is one of the ways into that. It's not for the GMC to design those, so our job is basically to make sure that people coming at the other end of that process meet the skills and knowledge requirements that we set. Equally, however, we do not want the reforms to lead to a bunch of thinking that isn't fully formed and that's going to set people up to fail. So I think we do have a vested interest in making sure that medical degree apprenticeship routes or four-year medical degrees, which is another area that's been mentioned in the long-term workforce plan, actually generate doctors with the skills and knowledge that they need. The other point, though, is also about where we train doctors. We know that we have a real geographical concentration of medical school places in London and the South East. And I think that is something that is a problem for those areas that are relatively under-doctored. And a really important balance in thinking through the education reform is how to temper the understandable and welcome desire from politicians to move at pace to increase numbers, but at the same time to do that in a strategically coherent way that focuses on place as well as pace. And that might mean actually just perhaps taking a little bit of the pressure off the timing so that we can make sure that those places where there is essentially a new infrastructure that needs to be built to support that actually has a chance to succeed, because otherwise we'll have people chasing down the numbers and saying all we need to do is to just double the intake in all of the kind of medical schools in London and the South East. And I think that would be a really missed opportunity, and I really hope that we can help at the GMC ensure that those that take those decisions do so in a strategically coherent way. So great question, thank you, Richard.
Thank you, Charlie.
I think the only thing I'd say is that in Leicester we've done a bit of work trying to reaching out into the more deprived areas in schools. So one of the things our clinicians have done is set up sort of boot camps and gone into schools and really tried to attract and offer practical experience in hospitals for those children who are in lower socioeconomic. And we have had some success in recruiting. So that's just another option, I guess, that all places are probably addressing as well.
Yeah, thank you. Hannah, we've got a question to the right of you there, and then I'll go, did you want to? No, the microphone will come to you in a moment. Okay.
Thank you so much. Thanks for the start. I am Dr. Girish Kunigiri. I'm the Medical Director in Lincolnshire Partnership NHS Trust. Two questions. Probably it is more to you from the GMC. One is...
Excuse me, could you hold the microphone slightly closer? Yeah.
Yeah, thank you. So my first question is, I keep hearing, particularly in Lincolnshire, because of the geography, we always struggle in terms of recruiting people. And I hear that nationally, the number of people after finishing their medicine, they are planning to leave the country. So my question is, what is that the GMC is actively planning to work with all the organizations in terms of minimizing that exit? So that was one. The second thing is, many years ago, we had the scheme of recruiting consultants directly from abroad to consultant posts. And I'm one such example. I came through the International Fellowship Scheme about 20 years ago now. So that scheme is no more in existence, and we have so much of gaps with the consultants recruitment, and growing your own workforce is obviously a good one, but it takes many years. So I was just wondering what the GMC's view is about reigniting, that fellowship scheme. Thank you.
Thank you. Thanks for your question. I'm going to go to Charlie first.
Thank you. So I'll take the second one first, if I may. So our job at the GMC is to make sure that the process is as seamless as possible for doctors that want to come into the UK from overseas. It's not our job in terms of the employment and deployment of those doctors, but the numbers have gone up massively, and actually, for the last full year that we've got, we had nearly 24,000 doctors coming into our register. Only 8,000 of those coming out of the UK medical school. So the number of international doctors coming into the UK has gone up enormously. Obviously, there are different routes for doctors to come in. So many of those take our PLAB tests, which are the knowledge tests that happen all over the world, and then the skills tests that happen in our offices in Manchester. But there are also other routes. So there are routes, particularly for doctors with particular postgraduate qualifications that we would recognise. We work with colleges about the recognition of those. And there's also the medical training initiative number. So those are doctors coming in specifically with a kind of earn and learn deal with trusts. The question about other routes in are questions that we're always happy to work with government and NHS England and others around. But I think at the moment the picture actually is if I look nationally, that the numbers coming in, the numbers of doctors that want to come in, we are able to kind of manage that, and we've massively ramped up our capacity at the GMC to enable that to happen. The other question you asked was about leavers. So our data is quite interesting actually around leaver rates. So overall, the number of doctors leaving the profession has only just tipped up to where it was pre-pandemic. So it's risen from last year. But the number of doctors that say they want to leave is worrying, and that I think is a function of what we see around burnout and stress. In relation to doctors going abroad, I don't think the data yet enable us to kind of see whether or not there is a long-term trend. So trainee doctors have always wanted to spend time abroad. We've seen more of that happening now at the end of the F2 year than previously. Obviously, doctors who've left in the last year, we can't yet tell whether they're going to do what doctors of previous generations have done, which is come back within a year or two. My guess is the vast majority of them will, though obviously what we heard from the Secretary of State this morning about wanting to resolve the industrial action will probably be the biggest single thing that is going to give doctors more confidence in their determination to stay working in the NHS.
Thank you, Charlie. I just wonder if you want to comment particularly on that minimising exit point, because I think some of what you've been focusing on.
I suppose just leading on from that, in hard to recruit sort of areas and specialties that are hard to recruit to, I guess one option, we know that now more locally employed doctors are converting into training posts. So we've done quite a bit of work about developing portfolios and interview skills and so on to allow them to access that training route. But again, that's not a quick fix, is it, to get to that consultant level? And then I guess the new specialist grade level is another opportunity, because these are really senior doctors that can practice autonomously. We had guidance for that sort of practice. So I know you've alluded to grow your own. And again, it's not a quick fix, but we do have some really quite experienced international medical graduates coming into what we'd previously sort of regard as middle grade registrar posts. So I guess it's taking advantage of that group and recognising their skills and value and offering them routes, for example, to accreditation through the new portfolio pathway. And I think having local opportunities for young doctors who may want to go abroad, but equally they just may need a break for a year or so, and offering them the sort of attractive posts that allow them to build their skills and giving people a good welcome, I guess, and feeling integrated in the organisation may help retain people in the different areas. But I think there is this disparity, isn't there, in the more rural areas in terms of attracting and keeping workforce. It's really hard.
Thank you. And come to the gentleman here. The microphone's just on its way.
Thank you very much. Can you hear me okay?
Yep.
Matt Ravel, I'm a medical director at the Royal Orthopaedic in Birmingham. Apologies, I just missed the first minute, so huge apologies if you covered it already at the start. My question is around physicians associates and anaesthetic associates and what the latest is on progressing them and bringing them inside the tent.
Okay.
I think that's for me.
This is squarely a GMC question.
So you didn't miss it. We didn't talk about it earlier. There is a very big debate. I think at times quite toxic debate, if I'm honest, about physician associates and anaesthesia associates. We should remind ourselves that PAs are not new. They've been in our health services for some years. And I believe that a lot of the arguments that are being made around PAs and AAs are actually arguments that are actually demonstrate the benefits of regulation. So from a GMC perspective, the fact that government is intending to legislate to enable the GMC to regulate these roles is something we very much welcome. I do think some of the toxicity in terms of the current debate is heavily influenced by the industrial relations climate that we have at the moment. And I think PAs and AAs have become weaponised in that debate. I'll be perfectly candid and frank with you all, particularly in terms of some of the debates around pay. So again, hearing the new Secretary of State earlier talking about wanting to end the industrial action, and clearly with a mandate from the Prime Minister and Chancellor to do so, I think is something that we should all very much welcome. And I think if we can get to the other side of that, and if we can get to probably in about a month's time, the legislation being enacted in Parliament that will bring those into regulation with the GMC, I hope that we can turn that into a slightly more constructive, positive conversation. And one, our PAs currently in the workforce and those students coming through actually feel welcomed and feel more psychologically safe, because I'm seeing some things that make me quite anxious in terms of what some of those people are telling me. I should say, just to finish, I have also been around a number of health trusts and health boards where there are groups of PAs working, and my observation is where there is a critical mass of PAs working, actually the conversation is a very different one, both from PAs and from doctors that they work alongside. It's a very positive one. There is an understanding of respective roles, there is a respect, and I'm always an optimist. And I hope that the more places that are like that, the more we'll see a bit of a tipping point and a change in the debate. But no, thank you for raising it.
Thank you. We've only got a couple of minutes left, so I'm afraid I'm not going to invite any more questions from the floor, but I am going to take Chair's prerogative just to take us back to one of the key issues that I think lots of trust leaders who are sat in this audience probably want your views on, and I'll go to you first, Nicolette, which is, how do we make sure that training time is protected? Because I think it's one of the themes that comes through continuously, and I think, what's your one top thought or tip on that?
Yeah, it's really hard. So in terms of winter pressures, I think in terms of morale for our postgraduate doctors, I think cancelling training afternoons, cancelling lunchtime teachings for service pressures sends out completely the wrong message. So I think from a practical point of organisation, if we don't do that, I think that's really helpful. I think it's also about trainers as well. It's about supporting our trainers to advocate for our trainees as well, and making sure that we recognise in terms of SPA time for our trainers to be able to deliver that training, because a lot of training is about supervision as well, isn't it? That on-the-job supervision that you do every single day. So, and I think it is hard, but I think you do have to allow consultants a little bit of leeway in terms of delivering that training time and having dedicated time in their job plans to do it. But I haven't got an easy answer.
No. Charlie, your thoughts?
So I think it's a really hard question. My argument would be it's a false economy not to protect training time either for trainees or for trainers. There are many places that do it and do it well, and where it happens and happens well, yes, of course it requires harder thinking about rota planning, service planning, but what you get at the end of that are trainers who feel more fulfilled in their role and more productive, trainees likewise. And so I'm afraid it's a bit of a kind of grit our teeth moment. From the GMC, we're advocating more explicit protection of training time, because I think that is probably the only way into it. But I recognise it's hard. But that point about it being a false economy not to do so, I think, is something that all of us need to take away and talk about around the various board tables that people here will be talking about this.
Fabulous. Well, I'm afraid we have come to the end of the time on this session. Thank you for your questions, but thank you particularly to Nicolette and to Charlie for their contributions. And I think we've heard some really great ideas and some really great thinking around this really important issue. So thank you both.